afternoon, everybody. And I suppose Professor Heinz Drexel is being on the online. Professor Heinz Drexel, are you online?
Yes.
Yeah, hi, how are you?
Hi. Fine, and you?
Still good morning in Germany or in your country?
It's in Austria. It's very early in the morning, yes.
Okay, very good morning. So I have an honor and privilege to be the chairperson for this lunch symposium, sponsored by the 𝗘𝘅𝗽𝗪. And we're going to have a very useful and very helpful for the clinical practice one symposium on the metformin, which is the OD actually, because it's been in the clinical use since 1957 in Europe, and the report was reported by the physician, French physician from the Yingstand in 1957. Since then, it's been used in Europe. When I trained endocrinology in the 𝗘𝗅𝗽𝗪 infirmary, now we use it very commonly. However, in US FDA, it is approved only in 1994. So on the arrival, I was there, then only the United States started to have its use. So the experience of metformin in the United States lagged 37 behind that of the European physicians. Today, we're going to look into the metformin 360-degree cycle, because as you have been noticed, there has been a great successes in the pharmaceutical management, pharmaceutical metformin, in terms of GLP-1 receptor agonists and the SGLT2 inhibitors and onwards. And there have been several trials, landmark trials, which have improved our decision making in the management of diabetes mellitus. However, as far as the pharmacological management of diabetes is concerned, metformin is still recommended as a first line of agent by most of the guidelines globally. And I think it is high time for us to review where we are now standing as far as the metformin is concerned. So I have requested Professor Heinz Drexel to give a talk on the metformin 360-degree. We want to exploring the future of the diabetes care. So I have a great pleasure to introduce Professor Heinz Drexel to you. But in terms, I want to give more time for the sake of discussion. I will just briefly, I hope you don't mind, I will just briefly introduce you with some salient point. Professor Heinz Drexel is being a scientific advisor and president of the VIT Research Institute. VIT, as I understand, is the 𝗘𝗂𝘁 Institute of the Vascular Investigation and Treatment. So he's being a scientific advisor from that research institute. And since 1997 to June, he's been the head of the research institute of the VIVT. And since 2006, he's been full professor of medicine, in particular cardiology and endocrinology in UFL. And since 2022, December, he's been a scientific advisor for the 𝗘𝗅𝗪𝗧. So there are several, a long list of CV. However, I hope you understand. I just want to give you more time for the discussion. I just briefly introduce you to the audience. We are looking forward very eagerly to listen to your very interesting topic, the oldies, but still it is goody metformin. The topic is metformin 360-degree and exploring the future of diabetes care. So, Professor, ladies and gentlemen, as you share with, please welcome Professor Drexel.
Good afternoon, ladies and gentlemen. It's a pleasure to work with you upon metformin 360 degrees, exploring the future of diabetes care. This 360 degrees is a very good framework for what we are doing the next 40 minutes. I have no conflict of interest. And again, the 360 degrees can be split into our outline, and we start with the history of the drug. The drug is metformin. It was first introduced into the clinical management of diabetes in 1957. So if it would be a worker, it would be retired now. However, it went on. 1970, the UGDP program showed that the other biguanides are not good for treatment, like fenformin. In 1998, there was a big step forward in the UK PDS study, and it showed that metformin is one of the best drugs available to prevent cardiovascular events. And in 2022, it was prescribed as the primary glucose-lowering agent for type 2 diabetes in most countries. So we have a timely drug, and we have long experience with old-fashioned studies, which is a bit a shortcoming, as we will see in the next minutes. Now, if you go on to the mode of action, this drug is working in the gastrointestinal tract. Metformin affects glucose uptake and absorption. It increases glucagon-like peptide 1 secretion, and it alters the composition and structure of the gut microbiota, and therefore it modulates also the immune response. The mechanism of its therapeutic action is not fully understood. If we go on and look at a recent review article by the Austrian Professor Schärmtaner and co-workers, then we can draw this picture and summarize the mechanisms for the anti-hyperglycemic and cardioprotective mechanisms of metformin. Left, the anti-hyperglycemic mechanisms. The drug is working against insulin resistance in the skeletal muscle. In the adipose tissue, it works on the lipid homeostasis and glucose metabolism. Most importantly, probably gluconeogenesis is reduced in the liver, as is insulin resistance there. And in the gut, we have a glucose turnover that is increased. On the right side, you see the many facets of cardioprotective mechanisms from myocardium to vasculature and again to the gut. Now, if we go on to the point that we want to address first in the clinical sense, it's diabetes prevention. Of course, if you want to prevent type 2 diabetes, lifestyle is important, and it encompasses weight reduction, change in diet or nutrition, increase physical activity and exercise, and smoking cessation. This is long-term knowledge, and you all know that. And the basis for the prevention of diabetes by metformin comes from the DPP program, published long ago, where it was shown that against placebo, metformin and lifestyle reduce the incidence of newly detected diabetes over about 4 years in the primary study. And you can also see that metformin is not as effective as lifestyle. So you could say about half as effective. Therefore, we can summarize at this point that lifestyle changes and treatment with metformin both reduce the incidence of diabetes in persons at high risk. However, the lifestyle intervention was more effective than metformin. Now, long ago, as we said, that a long-term effect of these interventions has been published later on in Lancet Diabetes Endocrinology about 10 years ago. And you see here the same pattern arises again, with lifestyle being double as effective as metformin. So over 15 years is the the bottom mark here. Now, if we go on to our fourth chapter, which is the main chapter, it's cardiovascular prevention by metformin. And here I want to just show you and make you comfortable with the classes of recommendation we have at the European Society of Cardiology. The classes of recommendations are 1, 2, or 3, and 2 is split into 2A and 2B. What do they mean? It's like on a traffic light. Class A means it is recommended. Class 2 means in the case of 2A should be considered. B, it may be considered, and 3 is not recommended. So that's the class of recommendation, COR. The other point is the level of evidence. Data derived from multiple randomized clinical trials or from one meta-analysis are level A. Level B is data derived from a single randomized clinical trial or large non-randomized studies. And level C is a consensus of opinion of the experts or smaller studies. So with that in mind, we should now scrutinize the different knowledge about the benefits and safety of metformin. Now, first, if we look at the guidelines that have been developed by the ESC in 2023, the latest ones we have, then we can say, and now your interest will focus again on metformin. The lower the risk is, this is on the left side, metformin is class 2A, low risk and moderate risk. Then metformin plus SGLT2 inhibitor and GLP-1 receptor agonist, class 2B, with high risk and very high risk, and class A is for the new drugs, GLP-1 and SGLT2 inhibitors. Now, you certainly know that in history we did not have these good drugs and these good studies, this quality of studies. So therefore you will not find in the green field what is to be said about metformin. Now, if we go on with these guidelines, then you see, perhaps let us start on the right side. We see that metformin is considered in the guidelines in patients with type 2 diabetes without atherosclerotic cardiovascular disease. In patients with target organ damage that is severe, the same, it is also level C evidence. As I said, the studies are not available. And with a calculated 10-year cardiovascular risk, it's also 2B. On the left side now, you see that it is recommended to prioritize the use of glucose-lowering agents with proven cardiovascular benefits, followed by agents with proven safety over agents without proven benefit or proven safety. This is, of course, a level C recommendation. Now, if you look at the 1A recommendations, then you see the SGLT2 inhibitors and the GLP-1 receptor agonists are in favor. So if you look at modern cardiodiabetology, you must say the newer drugs are in favor. However, if you look again on metformin, a very good point of metformin is additional glucose control. If this is needed, it should be considered anyway. And pioglitazone with a bit less strong recommendation can also be considered in this way. Good. Now, cardiovascular considerations of older glucose-lowering medications not tested in dedicated cardiovascular outcome trials. Here we can summarize. First, no dedicated randomized trials to rigorously affect the cardiovascular safety or efficacy of metformin. Randomized trials that have reported CV outcomes with metformin are most commonly limited by small sample sizes and few cardiovascular events for analysis. Next point, the largest randomized trial with the most encouraging cardiovascular results for metformin. Randomized trial of less than 1,000, let's say in this way, in the 𝗘𝗍𝗃𝗍, comparing conventional glucose targets with a policy of intense glucose lowering with metformin. However, with only 39 myocardial infarctions and 16 coronary deaths in the metformin arm of the 𝗘𝗍𝗃𝗍, as the precision of these efficacy estimates is largely uncertain. It's hope, but it's not proof. The upper confidence limits of each of the outcomes analyzed provided reassurance on the safety of metformin. So we are not sure about efficacy. It may be beneficial, but safety is good. That's true. Now, if we go on, metformin should not be a prerequisite for considering SGLT2 inhibitor or GLP-1 receptor agonist treatments in the modern world for cardiovascular benefits. In patients already prescribed metformin, SGLT2 inhibitors and or the GLP-1 receptor agonist should be added independent of the need for additional glucose control. So we go away from the glucocentric view and also look at the compound mechanisms of these drugs. In patients with type 2 diabetes and atherosclerotic cardiovascular disease not treated with metformin, one should start with an SGLT2 inhibitor or a GLP-1 receptor agonist. But this should be the first line. Metformin should be considered for those who thereafter want additional glucose control. So again, don't forget glucose and diabetes. Class 2A recommendations for metformin are based on the weight of opinion rather than on the weight of evidence. We have seen that in the tables before. If we go on, and this is the third of these slides, the results from meta-analysis of observational studies suggest associations with better cardiovascular outcome. But this is not supported by results from meta-analysis restricted to randomized trials in patients with type 2 and ASCVD, where no statistical significant effect of metformin has been observed for any major cardiovascular outcome. We soon look at the levels of outcomes. In patients without cardiovascular disease or severe target organ damage at low or moderate cardiovascular risk, treatment with metformin should be considered based on the metformin data from the randomized subgroup with overweight and obesity from the 𝗘𝗍𝗃𝗍. For patients without ASCVD or severe target organ damage at high or very high cardiovascular risk, treatment with metformin may be considered based on expert consensus of the task force. So, observational studies and meta-analysis, how could we summarize? Many observational studies and meta-analysis of the effects of metformin have been published. Demonstrations of reduced mortality risk and or cardiovascular events compared to noformin and meta-analysis show or may not show a reduced frequency of cardiovascular events or deaths. So there is a marginal effect. Study duration is critical. Meaningful results in 𝗘𝗍𝗃𝗍 were achieved only after 6 years. Now, the evidence for metformin monotherapy, I want to shorten here a little bit. It is best shown in the already quoted 𝗘𝗍𝗃𝗍 study. And here you see in green the outcome for metformin as compared in red the just conventional average treatment. And you see in the left panel that any diabetes-related endpoints are reduced considerably, as shown by the green line, which is metformin. If you look at the death rates, which are depicted in the right side of the picture, you see that again metformin is better and year by year becomes better than the conventional treatment given in red. So yes, we have from this small study clear results. Metformin reduces the mortality in obese diabetic patients. This is an important sentence. Metformin reduces mortality in obese diabetic patients. So we must keep in mind that this sub-study was conducted in obese diabetic patients. However, this subgroup of obese diabetic patients is the most important one we are challenged by in modern diabetology. So if we then look 10 years later, then we see that the metabolic effects of drug therapy in type 2 diabetes are characterized. If we take metformin as a basis, then you see insulin in red, sulfonylurea in blue. Then you see the change in weight is always with these two attempts positive, which means metabolically negative. So weight gain is the problem. In patients with obesity, this is also true. If in the two lower graphs we look at the change in plasma insulin, we see that especially insulin, of course, increases plasma insulin, and this also particularly holds true in the bottom right graph in patients with pre-existing obesity. So we now focus on weight gain and can say that metformin is beneficial in the 𝗘𝘅𝗽𝗋 study group. No weight gain with metformin is the bottom line. No weight gain with metformin. 10 years later, Rory Holman and colleagues showed that the 10-year effect after 𝗘𝘅𝗽𝗋 was the following. For microvascular disease, you see there is a benefit with sulfonylurea and insulin. A bit less so probably with metformin in the panel F. All-cause mortality in G is shown that it is also better after 10 years, called a legacy effect, but H, the segment H is most important. The all-cause mortality was significantly reduced by metformin. So the hardest of our endpoints was very well and for long-term reduced. All-cause mortality was better with metformin than with conventional therapy. If we look into the time course, you see that infarction remains stable, reduced. On the left side, at the margin of significance with sulfonylurea. On the right, you see with metformin, from the beginning it was clearly and significantly reduced. Metformin did reduce myocardial infarction. Sulfonylurea, insulin perhaps did so, but you had to be very patient and to wait very long until you could discern an effect. Now, metformin and mortality in type 2 diabetes and heart failure, you see metformin is positive to the left, even in combination with sulfonylurea or insulin. However, sulfonylurea and insulin alone or insulin per se increase the hazard ratio. With that, we can make this update. As we stand today, we have evidence for cardiovascular protection with metformin, including from randomized trials, many observational studies, and substantial experimental data. However, the nature of the clinical trial evidence has been overtaken by the new constellation of outcome trials that were designed to address questions of clinical safety that were formulated long after the randomized evaluations of metformin were conducted. So interpreting the current evidence base for metformin is undoubtedly a challenging risk, but no less important for that. So I think if you are considering metformin as one of your favorite drugs, now you have some very good cards. A short summary could be that metformin and heart failure shows two important considerations. Metformin can be prescribed in patients with stable heart failure, but there is a limitation. It is contraindicated for patients with decompensated heart failure. Now, the clinical outcomes under metformin treatment in patients with type 2 diabetes and heart failure. Reduced mortality risk is found when compared to non-metformin controls, so this is a very encouraging finding, and reduced hospitalization also. Significant reduction in mortality, especially for patients with preserved ejection fraction over 50%, is also a remarkable finding in heart failure. Now I want to show you the hierarchy of endpoints in randomized clinical trials. We have in our working group at the ESC concentrated on the type of endpoints, and you see we have objective natural events that are very trustable. We have the mortality, of course, we have the cardiovascular mortality, we have clear infarction and stroke. In contrast, we have events that depend on physician's decision, like revascularization or hospitalization. So we want to stick with the hard endpoints, which are objective natural events. And in this context, it is very important what we have considered just now and what we will consider in the next 20 minutes. Now, if we now focus on RCTs, on GLP-1 receptor agonists, I want to show you here an interesting finding, namely look at the column just at the right end. You will see that total metformin was very important in this study. So at baseline, 3 out of 4 patients had metformin aboard. So these are the modern studies. This does not mean that without metformin they were not beneficial, but we should keep in mind that the background was that 3 out of 4 patients in the trials like Pioneer, Rewind, Leader, and so on, Sustain 6, were on metformin, a combination therapy. The same holds true for SGLT2 inhibitors. Look here, 80% on metformin. Or DPP4 inhibitors, look here, 70% on metformin. So this is the necessary clinical reality in diabetes, that patients recruited for the studies with the new drugs always have a high proportion of metformin pre-treatment. Now, if we look at some other papers, we could say that diabetes medications as monotherapy or metformin-based combination therapy by Marutur et al. Show that the strength of evidence, if you look to the right end of this picture, for all-cause mortality is low, for cardiovascular mortality is moderate, and for cardiovascular morbidity also is low. What is the headline here? Effects of metformin compared with sulfonylurea monotherapy and long-term all-cause mortality and cardiovascular mortality and morbidity. So there is a small advantage for metformin treatment, but the strength of evidence is between low and moderate, best for cardiovascular mortality, so for the fatal infarctions. Good. Next, the cardiovascular risk following metformin treatment in patients with type 2 diabetes from another meta-analysis, also sponsored by the IDF, coming from China. You see here, if you look at the bottom, the overall the overall benefit was a risk reduction to an odds ratio of 0.57, so quite a good mark for the cardiovascular diseases risk following treatment with metformin in patients with type 2 diabetes. So again, the positive points for metformin emerge further. So if we here now come to a summary in the point of all diabetic patients should be treated with metformin, this is a very strong statement, but every strong statement has exceptions. For example, it is impaired kidney function, lower than 30 ml per minute glomerular filtration rate. Concurrent active or progressive severe liver disease, so no good place for metformin if kidney or liver are not good. Active alcohol abuse, unstable or acute, and I showed you before, acute heart failure, not heart failure by itself. Past history of lactic acidosis during metformin, of course. If you can't tolerate a drug, then you shouldn't take it. Decreased tissue perfusion or hemodynamic instability due to infection or other cause. So a rough summary of this side is the unstable or the acutely ill patient should not have metformin, and I would suggest if he is already on metformin, pause the treatment and restart it if the acute situation is overcome. Now we are in the real world, and this is the last point I want to show you here, and this comes from our institution. We have looked at secular trends in cardiovascular pharmacotherapy, for example, also in diabetes, also in lipids and in others, and I want to show you here a recently published study from our group. This was accepted November 8 last year, and we looked at 3 decades of glucose-lowering therapy in patients at high cardiovascular risk. So now we focus on high cardiovascular risk, and if you go through that with me, then I can show you we have made 3 studies. The one is 1999 to 2000, the next one 2005, so about 6 years later, and the last one is 2022, and you see in these populations that were selected by the need of coronary angiography. These are coronary patients. The coexistence of type 2 diabetes, the prevalence, is slightly increasing, significantly increasing, also by the fact that we have more newly diagnosed diabetes. That's just that you know what population we are speaking of. Now, if you look at the left panel, that was in the first era, there we had a lot of sulfonylurea in the year 2000, and in the right panel it was a bit less, and there was more metformin then, so this was 2005 to 2007, according to the new guidelines. So metformin substituted sulfonylurea. Yes, so that was the main finding here. Some other small segments appeared already. DPP4 inhibitors were just at the beginning of their short career. As you know, the DPP4 inhibitors are no more in fashion now. If we now go on and compare the second and the third stratum, you see all of a sudden we now have SGLT2 inhibitors in those heart patients as the majority, but still metformin is at the same level. And the DPP4 inhibitors are going back already. GLP-1 receptor agonist just coming to the market. So now the question is, at this time, what are the HbA1c values? You see the percentage of HbA1c patients that whose HbA1c is lower than 7% is slightly increasing. So the quality of glycemic control is increasing, especially in the last segment, in the last years. So the glucose lowering therapy, in conclusion, we could publish is that oral therapy is more, insulin is less, SGLT2 inhibitors increase. Metformin is still widely used, particularly in combinations. Sulfonylureas and other old substance classes go down, and GLP-1 agonist, receptor agonist use is still low, but this will, in Austria at least, change substantially in the next months and years. And we have more complex medication regimens. That means we have, as is also written on this slide, we have more primary combination medication, which is also true for hypertension, for heart failure, for lipids in our modern times. So, in summary, we are just lacking a look at the future now, and the future of metformin in diabetes care. What could it be? The future of diabetes care, particularly with metformin, is evolving significantly due to advances in precision medicine, drug delivery, and our understanding of diabetes itself. While metformin remains a foundational therapy, especially for type 2 diabetes, its role is shifting as newer technologies and treatments emerge. Metformin as a foundation, not a finishing line, could be a perfect summary. Metformin will likely continue to be first-line therapy due to its safety, low cost, and effectiveness in lowering glucose. However, newer drugs like GLP-1 receptor agonists and SGLT2 inhibitors are being prioritized earlier in high-risk patients due to cardiovascular and renal benefits. Combination therapy from the start, including metformin, is becoming more common, as I said before, and achieve quicker control earlier and reduce complications. Personalized and precision medicine, pharmacogenomics will soon help the right patient for the right drug. And we should not forget that metformin's effect is partially gut-mediated. New delivery systems, efforts are underway to improve metformin's tolerability. I think you as clinicians know that the gastrointestinal side effects are a problem to limit the use of metformin and are a real problem in the clinical practice. Extended release formulations may be good, microparticle or nanoparticle delivery may be beneficial, and transdermal patches are in experimental research. So delivery systems may be a further plus for metformin. Point 4, role beyond glycemic control. Metformin's benefits have been discussed very much in the fields of anti-aging, of cancer, and of polycystic ovarian syndrome and fertility. Digital health integration is the 5th point. Metformin regimens will increasingly be managed by the help of wearables, continuous glucose monitors, further progress in diabetes, and I can tell you, I think in a few years everybody should have such a wearable continuous glucose monitor to know what is his body or her body reaction to different steps of nutrition, of exercise, and just to the glycemia over the day. This can help to induce lifestyle changes, and this means that patients may receive real-time feedback on how metformin is working for them, an approach that we adopt very often. Point 6 and last point is in patients with cardiovascular disease or chronic kidney disease, metformin may be de-emphasized in favor of drugs with direct cardiac and renal benefits like SGLT2 inhibitors, empagliflozin or semaglutide as a GLP-1 receptor agonist. Some guidelines now allow skipping metformin in favor of these newer agents for high-risk patients, but I think that is not the topic for us today, especially in third world countries and also in Europe. The good price of metformin is a big advantage. So in summary, what is ahead for metformin? You see on the left side the aspect and on the right side the future trend. It will still be first line, but increasingly combined or replaced. So a starter. Extended delivery systems may be a good help. Personalized medicine, microbiome perhaps will guide us better. Expanded indications are another field that was not so much our topic today, anti-aging, cancer prevention, polycystic ovarian syndrome, and in guidelines we could expect some shift in high-risk population away from metformin, not in low-risk patients. With that, we are around our 306 degrees, and I thank you very much for listening to this aspect of metformin 360 degrees, exploring the future and the future of diabetes care. Thank you very much for your attention.
Thank you, Professor Drexel, for your excellent, very informative lectures on the metformin, which being in use for more than 68 years actually, and one of the commonly used drugs still in Myanmar, because the government, subsidized all the distributed metformin free of charge to all the even in the rural district, very remote rural districts. So it is still very useful, and your talk is very much helpful for us to continue to use metformin as a first-line drug in the district area, remote area. Thank you very much. Because although you talk very comprehensively, the conference is attended by many dignitaries and many prominent physicians from the whole country, and also from some from Cambodia and some Asian countries. I'm sure there will be some few questions coming up. Before that, I'm going to use the prerogative of being a chairperson of this. I would like to start a simple question. Metformin can prevent diabetes according to the DPP, Diabetes Prevention Program in the United States. The lifetime prevention is 57% efficacy. However, the pharmacological prevention is only around 30, if I remember correctly. But most of the commonly asked question in this country is that how much of metformin will be used for the prevention of diabetes mellitus? So could you please answer what is the prevention, what is the dose of metformin for the prevention of diabetes in pre-diabetes patient? This is the first simple question. Could you please clarify us? Could you please enlighten us?
Thank you very much, Professor Latt. That was a very good summary you made, and thank you very much for giving me the opportunity to speak at this lunch symposium. Now, to tell the truth, we have a good basis on diabetes prevention by metformin, but the translation into daily practice in the healthy population in Europe is much less than this study showed. So metformin used at a dosage of 1 gram per day to 2 grams per day is rarely used in the obese patient who is pre-diabetic, but it should be used. However, more it should be used to exercise and to make a diet that probably in your country is much better than in the center of Europe or in the United States. So it is theoretically good to use metformin in this setting of the pre-diabetic obese patient. And it is the only drug that has been shown for many years to prevent diabetes. Now we are going to have more data on the GLP-1 receptor agonist, as you know, also in non-diabetic patients, so also pre-diabetic patients. But the point is that metformin is the best documented way to prevent diabetes.
Thank you. Thank you very much. So now the Q&A session. The floor is from the audience. You can comment, or you can make a comment, or you can ask the question. You can raise the question while you are having an opportunity of accessibility to the very renowned speakers here. Any questions from the audience? Professor 𝗚𝗏𝗧𝗧, she is the current president of the Myanmar Diabetes Association. She wants to raise some questions.
Thank you very much for your very informative talk. Regarding the metformin, we're using a lot, and in case of CKD, sometimes we used up to the very low GFR level as the patient not turning up to the follow-up, but I find it quite okay, still okay with the GFR up to 20 or so. So what is your opinion? What is going to change in the future? Stopping the metformin in the CKD patient will be extending down to the lower GFR level or not in the future? As we don't see we don't see any the lactic acidosis in these patients.
This is a very excellent question, expected from the president of the country in diabetes. And the point is that with metformin, you have made a very good statement, down to, I would say, down to 30 ml per minute, there is no question. We had the same in the years when we investigated SGLT2 inhibitors. It was very good in these patients down to 30 ml per minute. Further going down is probably not a problem with both drugs, except in the acute situation of, for example, drug-induced renal failure. So we will have to learn a bit more in the modern context of the poly drug, but I think I could agree very intensively with you. Around 25 ml per minute is a good way to treat with metformin and also with SGLT2 inhibitors. However, of course, we need a close monitoring of the renal function. The point with GLP-1 receptor agonists is even better. Here you do not so much interact with the glomerular filtration rate, and you have beneficial results from the outcome studies. In summary, I would say renal patients benefit very much now from modern diabetes therapy. And it is also, to go back to the question of the chairman, it is also important for prevention of diabetes to use these drugs. And you know, SGLT2 inhibitors now are used very often in non-diabetic patients. Thank you very much for this excellent question.
Thank you, Professor. And next question, Professor Linali, who is an eminent professor from Philippines. She's going to raise questions. Yes, Professor Linani.
Thank you very much for a comprehensive lecture, Professor Drexel. I would like to comment on your last slide of the gloom feature of metformin. I think this is a comment that I want you to comment on. I think we have to go back to the basic, because if we treat diabetes according to pathophysiology, metformin cannot be replaced by SGLT2 or DPP4 in the octet of the fronzo. So I don't think the insulin resistance in the liver, in the periphery, can be replaced by SGLT2 and DPP4. That's one. So we have to go back to the pathophysiology treatment of diabetes and not marketing pharmaceutical means. Because if we stick to the insulin resistance problem, I don't think our patients will get into the kidney and cardiovascular adverse outcome, where SGLT2 are being marketed for the treatment. That's my comment, Professor. Could you please comment on that?
Would you like to make would you like to respond?
This is a very good statement. I think I couldn't agree more, because if you look back to the 𝗘𝗂𝗽𝗵, this study was made in patients newly detected for diabetes. And clearly it showed that metformin was the only drug there that was beneficial. And the many problems with other diabetes medications like sulfonylurea or even insulin had 2 points. First, these drugs induced obesity or increased body weight. And second, they produced hypoglycemia, both effects that metformin does not have. And if you then consider the newer drugs, all that were successful have no hypoglycemia and no weight gain. Even some weight loss is very important for SGLT2 inhibitors, and even more so for GLP-1 receptor agonists. So I couldn't agree more with you. If we go back to the pathophysiology of the development of type 2 diabetes with metformin, we have really a weapon where we attack the basic problems. Thank you very much. That's a very good comment.
Thank you. And according to your discussion in the slide of the mode of action, you have mentioned about the effect on the gastrointestinal tract, GLP-1, and the gut microbiota and immune response. But I haven't seen the insulin resistant. Our conventional understanding is that metformin is the one of the drug which reduce the insulin resistant. So can you explain to me why didn't you mention about the effect of metformin on the reduction of the insulin resistant? Is there any role of metformin to reduce insulin resistance?
Definitely there is. And if you consider again the data on prevention, then you see exercise, nutrition, and metformin were the ones that in these patients with insulin resistance, what's the characterization of these patients, were effective. So insulin resistance, especially in the GI tract, both in the stomach perhaps, but in the intestine anyway, and mainly in the liver. We believe that over the decades that the insulin resistance in the liver is ameliorated by metformin very pronouncedly. So it was on the slide, but perhaps I didn't emphasize it enough. Thank you very much for this question. Definitely, and if you make a combination therapy with insulin, which often is necessary, then the 1 unit or the action per unit of insulin is much better under metformin. That is also a clinical experience, no doubt.
Okay, thank you. Is there any question from audience? Well, I still have one question. You have very nicely summarized what's ahead of metformin in terms of clinical use, formulation, personalized medicine, expanded indications, and rule and guideline. What I'm wondering is that is there any rule of beta cell preservation so that the use of insulin, the timing can be delayed, which was shown in the verified study where the vital gifting and metformin by using in the early onset can delay the use of timing of the metformin, timing of the use of insulin. So is there any rule in the beta cell preservation in combination with other medication? That is my last question.
That is also a very important question for the future of the patient, but also distinctly of the beta cells. And I know data that the metformin is the best tested drug that is increasing the survival of the beta cell. One important point, and this is very easy, is the glycemia. The glucotoxicity, the toxicity of glucose for the beta cell in the pancreas is the main problem why the beta cell loses its function or even is in agony. And any way you improve the glycemia will be good for the survival of the beta cell. So this glucotoxicity issue still is a very important issue. And with metformin, and this is the last point I want to make, with metformin you have a drug that is very effective in glucose lowering. For example, SGLT2 inhibitors are very weak in this way. So if you have a high glycemia, then SGLT2 inhibitor will improve it, but only very little. GLP-1 receptor agonists do well, similar perhaps to metformin, but it's an easy sequence of thoughts. The metformin is a very strong glucose lowering drug. Strong glucose lowering is good for the survival of the insulin producing beta cell. So the answer to your question is very easy. Metformin is here a first choice drug. And this is very logical in our physiological understanding. Thank you. And
Thank
I
you
want
very
to thank
much.
you. I want to thank you very much for inviting me to this lively discussion. And I have listened to the previous sessions. I think you have a wonderful Congress. I can only congratulate to the high level of scientific quality. So thank you very much that I could be part of this faculty.
Right. From our side, thank you much indeed to give a lecture. Although it's online, it is very informative and very comprehensive, and it reinforces our knowledge, what we have known, and the future of the metformin. Because although it is old, it is still useful. As I have said earlier, it is oldies, but it is still the goldies. It is still the goldie one. So I'm afraid, in terms of constraint of the time, I need to conclude the section. Before that, I would like to thank Prof. Heinz Drexel from my bottom of my heart for giving a very informative lecture to us, for giving a very precious time on Sunday, your private hours. Thank you very much for your talk. And also, I would like to thank to the audience for the there's a full number of attending on the group floor, and all the attention, active participation, and active listening to the lectures. Last but not the least, I would like to show my gratitude to the TTO Pharmaceutical Company for bringing about this symposium happen on this second day of the IEDC, International Diabetes Endocrine Conference. With that, I would like to conclude the symposium. Thank you very much. Thank you for your all. Thank you for your attendance. Thank you. Thank you, Professor. Have a nice day. Thank you.